Okay, thank you, Sarah. Good morning, everybody. I'm going to switch gears a little bit here from Sarah's talk. So I titled this talk, New Tricks for an Old Dog, Updated Diuretic Strategies in Heart Failure. Rationale for this is there's been a lot of new data that's come out, particularly on a topic that's been pretty stagnant for many, many years. And so I just wanted to give updates on ways we can decongest our patients. So see if I can get this to work. So the outline is as follows. So I wanted to talk just a little bit about the importance of decongestion and heart failure. I think we all know how important that is, but I think worth showing a couple slides highlighting that point. I was going to go through some diuretic targets. So we're kind of all on the same page about how to determine success when we're using diuretics. And then the majority of this talk is going to be focusing on the rise of the proximal tubule inhibitors. Really, the vast majority of data that's come out in the last year or so has been around these medications. So I think warrants a talk on that, and then I'll end with a few conclusions. So like I said, I think we all recognize how important decongestion is. It's people are very quick to point out that there hasn't been randomized controlled trials showing that diuretics help mortality or provide mortality benefit in patients with heart failure. And while that's true in the outpatient setting and stable heart failure, I think that's a little bit misleading on the inpatient side. And we're going to be mostly talking about patients with acute decompensated heart failure, where the goal generally is to decongest, which is going to be with diuretics. So there's a number of studies similar to this. This is one such study looking at over 1,500 patients that were in the PROTECT trial. The PROTECT trial was looking at adenosine receptor antagonists, but more importantly, every patient in this trial had a daily volume assessment by a clinician for up to 7 days or discharge, whichever came first. And they then stratified participants into having either significant congestion or mild congestion or no congestion at day 7. The way that was defined, which is going to be important because every study defines congestion slightly differently, is they use a composite congestion score of orthopnea, peripheral edema, and jugular venous distension. And so if you had one of those criteria, you were categorized as mild congestion. If you had 2 or 3, you were categorized as significant congestion. And if you look at all-cause mortality over 180 days, if you had significant congestion, you did quite a bit worse than if you had mild congestion. And then obviously the best group were those that had no congestion, again, at day 7. Similarly, if you look at heart failure rehospitalization at 60 days, the same pattern was evident. Again, lots of studies like this. I'm just going to show you one more. This was published in 2012. This was a study of just about 600 patients that were admitted to a single center with decompensated heart failure. Here, they stratified participants at the time of discharge as having congestion or no congestion, and then further stratified them between worsening renal function or no worsening renal function. That was defined as a creatinine elevation greater than 0.3. And in this study, they define congestion as the persistence of one or more signs or symptoms of fluid overload. So those could be things like an S3, pulmonary rouse, jugular venous distension, hepatomegaly, or peripheral edema. And what you're looking at here on the left graph, this is 1-year mortality or urgent heart transplantation. On the right, it is urgent heart transplantation, mortality, or heart failure rehospitalization. And if you look at the orange and black, these are the participants or the groups that had persistent congestion at discharge. Again, significantly worse survival than if you had no congestion at the time of discharge, kind of a pattern that's true for both graphs. This is the reason I picked this study. It's one of the many that we use now to advocate for kind of what Steve Coca would call acute renal success, which is tolerating a rise in creatinine during active decongestion. So if you stratify this between worsening renal function and not, In the green are participants who had worsening renal function, again defined by creatinine criteria, who achieved adequate decongestion at the time of discharge. There was no difference in outcomes for those groups in both graphs here. However, if you had worsening renal function in the absence of decongestion, you did markedly worse. So this is highlights the need to distinguish between, what's likely pure cardiorenal syndrome versus AKI secondary to things like acute tubular injury, AIN, atheroembolic disease, all the other things that can cause AKI during a hospitalization. And the issue is, despite the fact that we know that decongestion is important, and in fact, it may be the most important thing in terms of overall outcomes, we're collectively not good at it. And that's true even in large trials. So the dose trial is where we get our initial diuretic dose from, right? So 2.5 times your home dose in IV form is kind of the classic evidence-based medicine initial diuretic regimen. And that was utilized in the dose trial, which also looked at high versus low dose diuretics, as well as a continuous infusion versus bolus dosing. If you look at the second row in this column, a minority of patients were actually free from congestion at 72 hours. So it was less than 20% across the board, even amongst the high dose diuretic group, which only 18% of participants were decongested adequately at 72 hours. And again, in this study, the way they defined congestion was jugular venous distension greater than 8 centimeters, orthopnea, or greater than trace peripheral edema. And so, how do we do better? And one of the issues might be that our targets are not adequate. And so traditionally, we're all generally going to use things like net fluid balance and weight loss during a hospitalization. The problem is, is that the right thing to do? So Jeff Testani published this in 2015. He looked at the correlation between diuretic-induced fluid and weight loss in 3 relatively large trials. So this is combining the dose trial, the escape trial, and the PEN cohort. And again, looking at the correlation between fluid and weight loss with diuretics. This is a Bland-Altman plot here. I didn't totally understand this, nor do I even now. I had to ask Brian Kestenbaum how to interpret this, but essentially it showed that the correlation between those variables was extremely poor. My understanding is that you can't necessarily say if the discrepancy is, or which variable the discrepancy is secondary to. The authors concluded that was likely both. And so if we accept that ins and outs and weights, which can also traditionally be difficult to accurately measure during a hospitalization, are incorrect, what does matter? And there's been a growing body of evidence that what really matters during an inpatient admission is net negative sodium balance. So if you look at the 316 patients who were enrolled in the ROSE heart failure trial that had 24-hour urine available for sodium excretion, net negative sodium balance had the greatest association with better survival over a 6-month period. Gross urine output, net fluid balance, and weight loss actually had no correlation with overall survival at 6 months. And even if you had net negative fluid balance based on intake and output, if you had positive sodium balance, you still did significantly worse over 6 months than if you had negative sodium balance. The problem is this is not logistically possible. We can't be getting 24-hour urine collections in every patient every day who's admitted to the hospital. So what do we have control over? Well, one thing we do on our service, and we've been using consistently, is using spot urine sodium levels to at least gauge the appropriateness of natriuresis with diuretic therapy. And so if nothing else, I think it helps decrease your door to decongestion time, which we've seen is fairly important. So this was a prospective study of 110 patients out of Poland that had decompensated heart failure. They used a spot urine sodium, which is measured at 6 hours, 24 hours, and 48 hours after IV furosemide. And then there was a 1-year follow-up. In the red are going to be your participants that had a rise in their urine sodium in response to IV furosemide. In the blue are going to be your participants that had an unchanged or decreased urine sodium. The top graph A is at 6 hours, at B is at 48 hours. So essentially, if you had a rise in urine sodium after IV Lasix, you did significantly better than if your urine sodium was unchanged or if it decreased. Not only was mortality worse, these participants that did not have a rise in urine sodium also had higher NGAL and KIM-1 levels. I think that correlates well with what we know in terms of the biggest driver of acute kidney injury and cardiorenal syndrome, which is venous congestion. And the longer that lasts, the more likely you are to have acute tubular injury. Mean furosemide dosing was equivalent in these groups. And another way to think about this is this equation that Testani proposed back in 2016. We talked about this a little bit in Neph Madness for people that were at that session in the spring. And what they did here was they used this equation, validated it among 50 patients on their acute heart failure service against 6 hours urine collections for sodium. They then took this equation after validation and actually installed it in their pathway for their transitions clinic and utilized it to guide diuretic therapy and published those outcomes. Now, I don't use this equation. I don't know if there's anybody here that does. I'm not sure if David or Nietzsche, when they're on, use this. And so again, I pretty much just use urine sodiums and we differ a bit on our targets. So for example, I will use urine sodium greater than 70 after 1 to 2 hours after diuretics. I think on our diuretic protocol, we've used 50 and various studies have used various benchmarks. I think it's also important to note that while your urine sodium level seems to correlate with outcomes during your decongestive phase, it doesn't at the time of discharge. Now, this is going to be assuming that patients are either euvolemic or even dry at the time of discharge, but at least not, they don't have ongoing congestion. So this was a prospective study of 172 patients, 1 year mortality, looking at urine sodium. So again, if you look at outcomes, urine sodium during the decongestive phase mattered significantly, at the time of discharge didn't. This makes sense. If you are euvolemic or dry, your urine sodium generally will drop because of your proximal reabsorption of sodium. And so we'll actually measure this every day in our patients. So every morning, and if there's an acute drop in urine sodium despite no change otherwise clinically in your diuretic regimen, it may be a clue that the patient has been diuresed sufficiently. Now, that's never going to be our only variable. We're still relying on physical exam, often ultrasounds, DEXA scans, or lung ultrasounds, right heart cath, your kind of traditional methods of determining euvolemia. But again, this may be a clue. This slide's not meant to be read. It's just to point out that these are all the studies I'm aware of that have looked at spot urine sodiums to gauge your natriuretic response. And again, targets have varied from greater than 50 to greater than 100 in terms of determining success. One of the issues, though, is that all of these studies have just looked at furosemide monotherapy. When we use this on our service and practice, we use it with all change in management, whether that's sequential nephron blockade, adding dobutamine for patients that need it, adding vasopressin for pressure assisted natriuresis, whatever it may be. We don't necessarily have data on that yet. It makes physiologic sense to us, but that study is ongoing. So this is the decongest trial. This is currently recruiting. It's a trial out of Belgium, looking at using urine sodiums to guide all aspects of therapy in patients with decompensated heart failure. They're using a urine sodium greater than 80 to gauge success. Okay, so the thing is, as nephrologists, we generally don't get consulted if patients are admitted and are responding well to 40 of IV Lasix and they go home in 3 days, right? We're involved most typically when there's diuretic resistance. I've talked about this in prior grand rounds, but worth bringing up the nice Ellison diagram from his paper in the New England Journal in 2017. One of the most prominent etiologies of diuretic resistance is going to be your distal convoluted tubule hypertrophy, and you have upregulation of NCC channels. That's been shown numerous times. These are studies showing upregulation of NCC channels when you're exposed to loop diuretics. And so it's standard of care to add thiazides whenever you're not getting adequate response to loop diuretics. I think it's worth pointing out that we don't have that much evidence to support that practice. It makes physiologic sense, but really the only evidence comes from the CARES trial, which that wasn't the specific goal of that trial, but it showed that diuretic therapy using loops and thiazides was equivalent to ultrafiltration. And so that's, again, been common practice. One of the things that always bothered me was that, as we all know, the vast majority of your sodium is going to be reabsorbed in your proximal tubule, right? That's going to be about 65% in normal individuals. In heart failure, that goes up to as high as 85%. And two mechanisms that primarily drive this, I think. So with reduced renal blood flow, you get an increase in filtration fraction. So you're going to raise your peritubular oncotic pressure, and that's going to favor sodium reabsorption. You also have increased lymph flow, which is going to wash out your interstitial proteins in your interstitium. And that's also going to decrease your oncotic pressure and then further promote sodium reabsorption. So it's always kind of made sense to me that blocking your proximal tubule should benefit natriuresis. And so what's the history of that? Acetazolamide, as we know, is a carbonic anhydrase inhibitor, impacts sodium reabsorption in the proximal tubule. This was the first non-mercurial diuretic to be synthesized in 1952. The first study I know of that came out with this was in 1953 in the New England Journal. It was 26 patients, all with heart failure, that served as auto controls. I can't actually tell you what they did. Honestly, these studies are really hard for me to gauge from the methods what was actually done. But the bottom line was either oral or IV acetazolamide, so 750 milligrams, increased both urine output and natriuresis, which sounds like a good thing. The problem was by 1956, studies such as this in the Lancet came out, where they compared acetazolamide monotherapy to mercurial diuretic monotherapy. I think you can all predict what the outcome of that was. You're never going to bring acetazolamide to a loop diuretic fight. And the mercurial diuretic blew acetazolamide out of the water. And acetazolamide essentially gets relegated to things like, altitude sickness and glaucoma at this point. Doesn't really show up in the literature again until 2019, when a small study of 34 patients out of Belgium gets published. And this was a study of patients with decompensated heart failure who were given either acetazolamide or placebo. So participants got 500 milligrams of acetazolamide at the time of randomization, then 250 daily for 3 days, along with 1 milligram BID of bumetanide after a 2 milligram bolus, versus bumetanide at double the home dose in IV form BID. And the primary outcome that they were looking at was sodium excretion at 24 hours. And essentially there was no difference between the two groups. When you also looked at signs of congestion, again, no significant difference between two groups. What they did show was that loop diuretic efficiency was better in the acetazolamide group. So the way they defined that here was natriuresis corrected for loop diuretic dosing. And the takeaway here is that if you use acetazolamide, you can use lower doses of loop diuretics to achieve the same response, which may or may not be good, right? Now, this culminated in the ADVOR trial being published earlier this year. So the ADVOR trial is our largest randomized diuretic trial to date. This was a multi-center trial, so 27 sites in Belgium. And it was placebo-controlled, 519 patients. All patients had acute decompensated heart failure plus volume overload. To be considered for the study, they had to be on oral maintenance therapy with at least 40 milligrams of furosemide equivalents, but less than 80. So that was one of the key criteria for at least a month. Key exclusion criteria here was an eGFR less than 20, or use of an SGLT2 inhibitor. So patients either got 500 milligrams of IV acetazolamide every day versus placebo. Both groups got loop diuretics, and the primary endpoint was successful decongestion at 72 hours. And the secondary endpoint was a composite of all-cause mortality or heart failure rehospitalization at 3 months. So if you look at the results here, there was an increase in both diuresis and natriuresis in the acetazolamide group. And in terms of mean sodium excretion, it was 468 millimoles in the acetazolamide group, 369 in the placebo group. And similarly, 12% more patients were successfully decongested at 3 days. And that actually continued post-discharge, and 78% of patients versus 62% of patients were successfully decongested at the time of discharge, despite the fact that acetazolamide was only given here for 3 days. The congestion score was also better, and I'll show you that in a minute, how they determined congestion, which is a little different from the other studies. Patients in the acetazolamide group were in the hospital for an average 1 day less than participants in the placebo group. And maybe just as importantly, there was no significant difference in adverse events between the two groups. Specifically, there was no severe metabolic acidosis when given acetazolamide. Now, caveats to this is in the supplementary protocol, it was advocated but not mandated that if your serum bicarb dropped to less than 20, you'd be given an infusion of sodium bicarb. It is worth noting that serum bicarb levels were not part of the inclusion or exclusion criteria, and the mean serum bicarbonate in both groups was right around 27, slightly less than 27. And so something, typically acetazolamide is thought about in metabolic alkalosis. In this case, both groups had normal serum bicarbonate levels. The way they define congestion here, like I said, was slightly different. So to be considered successfully decongested, you had to have no more than trace edema, no pleural effusions, and no ascites. So overall, a successful trial. And the question is this all because of proximal tubular inhibition of sodium? The reason I bring that up is there's potentially another theory here. If you go back to Ellison's diagram, one thing that's generally ignored is that just like with your NCC channels, you have an upregulation of intercalated cells in heart failure. And if I blow that up, there's actually a mechanism of electroneutral sodium chloride reabsorption through the parallel action of pendrin and the sodium-dependent chloride bicarb exchanger. And so essentially 2 cycles of pendrin result in 1 sodium, 1 chloride absorbed via beta intercalated cells. The reason I bring this up is it's possible that acetazolamide actually downregulates pendrin. So this was a study, and I forgot to mention, this whole mechanism is upregulated by angiotensin II. And so obviously that's very relevant in patients with heart failure who are going to have higher levels of angiotensin II compared to controls. And again, so this study was in rats, and they either received a control, hydrochlorothiazide, acetazolamide, or they were pre-treated with acetazolamide for 6 days, and then received a combination of acetazolamide and hydrochlorothiazide for 4 additional days. That combination led to the greatest increase in both urine volume and sodium excretion. And then if you look at pendrin expression, acetazolamide downregulated pendrin, whereas hydrochlorothiazide did not. And if you look at the combination, pre-treatment with acetazolamide actually downregulated pendrin more than the simultaneous administration of acetazolamide and hydrochlorothiazide. So another possible mechanism for why acetazolamide is beneficial. So what's next in this field? So I think, it'd be interesting to study this in patients with diuretic resistance. That's the time that on our service, we're using it the most. This study was obviously upfront therapy in combination with loop diuretics. Be nice to confirm that oral dosing is just as efficacious. We use that quite a bit, but worth pointing out that all the studies used IV dosing. And then if anybody here wants to come up with the next diuretic, pendrin may be a logical target for that. What about the other proximal tubule inhibitors. So SGLT2 inhibitors, we know how effective these are in chronic therapy. What about in terms of their natriuretic response? So this was an initial fairly small study. So this was 20 patients. So this is stable heart failure. These aren't decompensated heart failure. This is chronic outpatients with heart failure who got empagliflozin 10 milligrams versus placebo. They got 14 days of treatment. There was a 2-week washout. Then they crossed over to the other therapy. All patients received bumetanide and their home dose was converted to IV form. And what they showed was on its own, empagliflozin had a very modest increase in your fractional excretion of sodium, but with loop diuretics, there was a significant potentiation of the natriuretic response. There was also a significant decrease in blood volume and plasma volume. What's interesting is that empagliflozin did not increase your neurohumoral levels, so norepinephrine, renin, et cetera, were not increased, whereas with loop diuretics, we typically will see that these levels increase, which may be bad in patients with heart failure. And this led to kind of the theory that SGLT2 inhibitors may selectively address interstitial volume without significantly impacting intravascular volume, and so may have a more favorable impact on perfusion, whereas loop diuretics do have an impact on intravascular volume. I'm not sure what the mechanism of this would be. There's animal models showing that SGLT2 inhibitors have a greater impact on tissue sodium levels than loop diuretics. But again, I'm not sure exactly what the mechanism here is. The question then is, what about in patients with acute decompensated heart failure? Can we use this to potentiate the effects of our other diuretics in patients in the hospital? And this is particularly relevant on the heels of the MPulse trial. So this was a trial that essentially showed that giving patients empagliflozin during their hospitalization was both safe and efficacious. So this was 530 patients admitted with either de novo or decompensated chronic heart failure. They were randomized to 10 milligrams of empagliflozin or placebo once they were clinically stable. That happened over a mean of 3 days. And then they were treated for up to 90 days with a primary endpoint that was a composite of all-cause mortality, heart failure events, time to first heart failure event, or a greater than 5-point difference on the Kansas City Cardiomyopathy Questionnaire and total symptom score. They set up their results as win ratios, and essentially empagliflozin was beneficial in respects to all outcomes, which may not be surprising because we know how effective these drugs are for chronic heart failure management. And again, probably more importantly, there was no adverse events between the two groups. So again, showed that this was safe to start in the hospital. But what about specifically the diuretic response? So in earlier this year, a single center study was published called the MPAG Heart Failure Trial. And it was a double-blind placebo-controlled trial looking at hospitalized patients with acute decompensated heart failure who are randomized to either 25 of empagliflozin. So note that that dose is very different than our chronic outpatient dose, which is going to be 10 milligrams, versus placebo within 12 hours of admission. All patients received similar doses of loop diuretics, and the primary endpoint was urine output over 5 days. What they found was that there was a 25% increase in urine output with greater improvement in BNP and also improved diuretic efficiency. The way that was defined here was milliliters of urine output production per milligrams of furosemide equivalents. This actually makes physiologic sense. It turns out that it seems that angiotensin II actually upregulates SGLT2 channels. So this was another rat study, and the infusion of angiotensin II increased the expression of SGLT2. The rest of the study was looking at the impact of losartan and empagliflozin, but I think the main takeaway was, again, very relevant to patients with heart failure. Angiotensin II appears to impact SGLT2 channel expression. One of the problems is I'm still not convinced as to the natriuretic response. Despite that small study that was published in 2020, this study in 2021, which was a pre-specified substudy of the EMPEROR response trial, again, double-blind, placebo-controlled, multi-center study, 79 patients, acute heart failure, randomized to empagliflozin versus placebo. And when they looked at your fractional accretion of sodium, it actually went down in the empagliflozin group compared to placebo, similarly with chloride. And this is despite the fact that they showed that empagliflozin was absorbed and effective as you had a pretty immediate presence of glycosuria. And when you look at your urine osmolality and urine volume, participants in the empagliflozin group did have more urine production. The problem was it was primarily driven by glucose in the urine. And so this suggests it was mostly an osmotic diuresis. It's worth pointing out that, again, patients here are only on loop diuretics. So as opposed to glucose, where once you get past the proximal tubule, you don't have the opportunity to reabsorb it, you're going to excrete it in the urine. Sodium obviously has multiple distal sites of reabsorption. So I do wonder if this would be different if patients had been on loops and thiazides to block distal sodium. And that's the population that we're primarily using this in when we're trying to increase natriuresis in patients with diuretic resistance. But that study, I think, needs to be done, or at least it would be nice if it was done. I'd also be interested in SGLT2 inhibitors versus acetazolamide, or the combination. They have distinct mechanisms. I know that David and I have both had patients that we have used this in combination. Anecdotally, we've seen some success, but it's a small number of patients, and it would be nice to study it if we could. So in conclusion, door to decongestion time is important. I think we have more tools to help us out, and that includes monitoring natriuresis. So you're not waiting the 24 hours to look at urine output, weight loss. You can escalate therapy within a couple hours. We finally have evidence for proximal tubule inhibitors. In fact, these are the kind of the largest diuretic trials we have. And I think additional studies and diuretic resistance would be really nice. And I'm just going to put up our diuretic protocol here. So Nisha, David, and I worked on this with the cardiologist, mainly Kevin O'Brien. Just to point out, we've been using urine sodiums, consistently to gauge success. We use greater than 50. That was a compromise. We've been using acetazolamide, and we may need to alter our at least the protocol in terms of SGLT2 inhibitors, which currently stated that if they're on it as an outpatient, you continue it. We've been starting it frequently, though, in the hospital. I'm gonna end there. I don't know if we have time for questions. I know we have a 9 o'clock.
I'll give you a minute, mostly because there is quite a few questions around the same topic, namely the effects of water handling in addition to sodium handling. So I'll start with Ian's question kind of early on, and then that was kind of works into Brendan and Ashley's questions. But Ian asked, isn't urine sodium concentration determined at least as much by water handling as by sodium handling? Brendan and Ashley also ask if there's been any thought to using a correction factor such as the creatinine or FeNA.
Yeah, so it's a good question. And so certainly if you have the more urine, urine sodium is going to be effective. We do know once you have a significant diuresis, 5 liters, so urine volume, you're gonna decrease that spot urine sodium. So it's more effective in those patients that aren't, let's say polyuric, let's say. Similarly with really reduced urine volumes, you're gonna artificially increase your urine sodium at times. So people have used FeNA. In fact, a lot of the studies in SGLT2 inhibitors used a FeNA. The question of water handling is also a good one. It's actually not clear whether the aquaretic part of this is effective. The one answer to this is, well, Vaptans have to this point not really shown significant benefit, although there's more ongoing studies looking at adding Vaptans to your kind of quote unquote sequential nephron blockade and impacting more of the aquaretic part of care. But it's a good point. FeNA, maybe we should be using FeNA more than urine sodiums, although all the prior studies have to date have primarily used spot urine sodiums.
Great, thank you.